I'm Adam Dulski, one of the Emergency Ultrasound Fellows, and today I'll be talking to you about deep vein thrombosis and its diagnosis using ultrasound. We'll start out with a common clinical case. This is a patient you could see in urgent care, primary care, but most likely in the emergency department. It's a 55-year-old male, left lower leg pain for 5 days. He has some concerning findings on history, most notably that he just drove back from San Francisco. Denies any recent trauma. He has no known past medical history. His physical exam is pretty benign. He has some tenderness to palpation in that lower leg, but no significant swelling. His neurovascular exam is intact, and his lungs are clear. So where do you go from here? So we're going to focus on bedside ultrasound. You can quickly evaluate his symptomatic leg and diagnose a DVT. This is a clot within the left common femoral vein. So we're going to get back to the basics to start. You're probably all familiar with this from medical school, but Virchow's triad: venous stasis, vessel wall injury, hypercoagulability. And how do these things translate to our patient's history? Trauma, surgery, immobility, prior DVT, exogenous estrogen use, hormones in general, but specifically estrogen. We would then go to the physical exam, but really, physical exam is not sensitive nor specific. We have some clinical decision tools like the Wells criteria, and in this case, you add a point to the patient for each positive finding on history, increasing or decreasing their pretest probability. So active malignancy, this is usually cancer treatment within the last 6 months. Paralysis, paresias, lower extremity cast, bedridden for 3 days or surgery in the past 4 weeks. Again, general anesthesia, major regional surgeries. Does the patient have localized tenderness along the deep veins? This is not varicose veins, which can be tender, but specifically along the deep veins. Is the entire symptomatic leg swollen? Is the calf swollen greater than 3 centimeters? You don't really need to know this measurement, but this is 10 centimeters below the tibial tuberosity, and then you compare bilaterally. Pitting edema, greater in the symptomatic leg. Prior history of DVT. And do you have an alternative diagnosis that decreases the likelihood of DVT? So this adds up to your pretest probability. Patients with more than 2 findings on history are going to have a high risk, 1 to 2 moderate risk, and 0 low risk. And this helps you decide disposition. High-risk patients may get more involved diagnostics, whereas low-risk patients might not get any diagnostics. Today we'll focus on diagnosis of DVT in the lower extremity. This is about 84% of DVTs, 71% in the femoral and popliteal region, and an additional 13% isolated to the calf veins. We won't be talking about the upper extremity today. We'll save that for a more advanced lecture. But that is the other 16%. So what options do we have as far as diagnostics? You have laboratory evaluations. D-dimer is probably the major one here, which is sensitive but not really specific. Imaging-wise, you have CT, about 95% sensitive, as well as 95% specific. This has the strength of diagnosing the areas in the pelvis, looking at the lungs, but you have to use contrast. The patient gets radiation. It takes time. It costs money. MRI, no radiation, but still a lot of money and time. Duplex ultrasound is fast, it's sensitive, it's accurate. It misses some areas of the pelvis, as well as the adductor canal, and some of the calf veins as well. But for the emergency department, it gets the areas that we're concerned about. We're going to be using a high-frequency, superficial, linear probe. And what we're looking for is an inability to compress the veins, findings of echogenic material within the veins, or Doppler abnormalities. Compressibility is really the big one. You want complete apposition of the vessel walls. Intraluminal material and Doppler are less sensitive. So how are we going to position the patient? For the femoral region, you'll put the patient in a frog leg. This helps to alleviate tension over the femoral triangle. You can really keep them in this position for the popliteal fossa as well. Some other options for the popliteal fossa you can see here: towel roll, lateral decubitus, or hanging the leg. But the frog leg works pretty well for both. So what are you looking for? We'll start our two-point compression protocol. In the two-point compression protocol, there are two areas or points where we are compressing. In the first area, you have the common femoral vein. Now this is most proximally. This is before the bifurcation. You first compress here, achieving complete apposition of the superficial vessel wall against the deep vessel wall. A good landmark here is your great saphenous vein, which you can see there laterally. We're then going to move inferiorly 1 to 2 centimeters at a time, compressing throughout. You'll start to see the bifurcation here, the superficial femoral vein and the deep femoral vein. You want to achieve complete compression, therefore apposition of both vessels. After completing the femoral region, you will move on to the popliteal fossa. So the popliteal fossa is our second point or second area in this two-point compression protocol. You'll see the popliteal vein is the superficial structure, closer to the skin than the popliteal artery. Again, you start prior to the bifurcation, and you compress, moving inferiorly until you see what we call the trifurcation. The popliteal artery remains as one vessel, and the popliteal vein bifurcates. Here are some other findings that you can look for in addition to apposition. You'll see sometimes, like we started with, echogenic material within the vessel lumen. You can also use your color flow and see if there is both good venous flow and arterial flow within the vessel lumens. Here you can see an attempt at apposition, but it is only partial. There is clearly echogenic material within the vessel lumen. You can see a more superficial vessel that is completely compressed. Here's an example of color flow. You have good color flow within what looks like the femoral artery, but no flow or minimal flow within the vein lumen. You'll see some flow around the perimeter. Finally, we'll review some pearls and pitfalls of this diagnostic procedure. We talked about the two-point protocol. This is what we use at bedside in the emergency department. You will see when radiology does a study, they often do a complete leg protocol. Where is the DVT? We can only evaluate the femoral, popliteal, and some of the calf regions by ultrasound. We miss iliac DVTs as well as pelvic DVTs with this modality. Watch out for duplicated veins. This is more common in the upper extremities, but you will see this in the popliteal fossa. Lymph nodes. Now we'll show some examples of these last three items. But lymph nodes can be tricky. They have some flow, and they can look like echogenic material. Pseudoaneurysms are also another pitfall. Baker's cysts behind the knee can trick you and look like a large dilated vessel. Let's take a look. Here is an example of a lymph node by ultrasound. You'll see if you look at one simple cross-section, it can look like a vessel with some echogenic material. If you turn color flow on, it will be scattered, almost looking like that picture we looked at a few minutes ago, where there's peripheral blood flow. Make sure you scan all the way through this and look at it in multiple planes. Baker's cysts are common findings in the popliteal fossa. This is an expansion of the synovium posteriorly. Now, the fact that you have a Baker's cyst does not eliminate the possibility of a concomitant DVT. Make sure you complete your evaluation in this region. Color flow can be something that can help diagnose a Baker's cyst, as there will be no flow, unlike a vein. Here is an example of a Baker's cyst by ultrasound. You can see in the appropriate cross-section, it looks like a vessel, but there's no flow. And it will also be difficult to compress. Pseudoaneurysms are common in the femoral region, especially after venipuncture or arterial puncture, as well as trauma. This is a dilation of the arterial wall, and you can see arterial flow coming up into the expanded arterial lumen. This is not a vein. I hope this brief discussion of bedside ultrasound for DVT using a 2-point compression protocol shows you how appropriately selected patients can be ruled in or out and decrease your time to disposition.